Hello, future nurses and NCLEX warriors. Welcome once again to NCLEX, where learning meets confidence and excellence. Here, we post 2 to 3 high-yield NCLEX videos every single day, carefully designed to strengthen your clinical knowledge, build your critical thinking, and prepare you for both the exam and real-world nursing care. In today's in-depth respiratory session, we are focusing on a topic that forms the foundation of pulmonary nursing care of clients with inflammatory and infectious disorders of the lower airways. This vital lesson covers diseases such as bronchitis, bronchiolitis, pneumonia, and tuberculosis, all of which test your ability to assess, intervene, and prioritize care effectively. You will learn the pathophysiology behind inflammation and infection in the lower respiratory tract, the hallmark signs and symptoms, diagnostic procedures like sputum culture and chest X-ray, and key nursing interventions including airway clearance, oxygen therapy, antibiotic administration, and infection control precautions. We will also highlight essential client education points for medication adherence, prevention, and long-term management. So stay tuned, take notes, and stay alert, because this session is packed with NCLEX priority concepts and real-world nursing applications. And remember, at NCLEX, we do not just help you pass the exam, we prepare you to save lives with knowledge, skill, and confidence. Let's begin today's powerful session on inflammatory and infectious disorders of the lower airways. Let me share something before we jump in.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now move forward with important respiratory scenario that tests both critical thinking and clinical reasoning. A client with a persistent upper respiratory infection develops acute bronchitis and is prescribed guaifenesin with codeine, also known as Robitussin AC. The nurse prepares to perform a focused respiratory assessment. Aside from documenting the characteristics of the client's cough, which additional finding is most essential to assess and record for clinical accuracy, here are the options. Option A, family history of respiratory disease. Option B, current vital signs. Option C, appearance of respiratory secretions. Option D, any self-treatment measures used by the client. The correct answer is option C, appearance of respiratory secretions. When caring for a client with acute bronchitis, evaluating the nature and quality of the cough is certainly key. However, the appearance of the respiratory secretions provides even more direct insight into the disease's progression and underlying pathology. The nurse should carefully document the color, amount, consistency, and odor of the sputum. For example, yellow or green sputum suggests purulent infection, often due to bacterial superinfection, whereas clear sputum indicates a viral etiology. Thick, sticky mucus implies dehydration or mucus stasis, while frothy sputum may point toward pulmonary edema. If the sputum emits a foul odor, this could indicate anaerobic infection or a developing lung abscess. Recording these features is vital for evaluating the client's progress and determining whether antibiotic therapy or further diagnostics like sputum cultures are needed. On the other hand, although assessing a family history of respiratory disease, option A offers useful background on chronic conditions such as asthma or chronic obstructive pulmonary disease, it does not provide immediate insight into an acute bronchitic episode. Similarly, recording vital signs, option B, is always essential, but it primarily reflects systemic responses, like fever or tachypnea, rather than local airway changes. Lastly, documenting self-treatment measures, option D, such as herbal syrups or over-the-counter medications, helps identify potential interactions, but is secondary to the more urgent evaluation of sputum characteristics that directly guide the treatment course. Transitioning now to our NCLEX clinical insight. The color and consistency of sputum are the lungs' diagnostic language. When the nurse listens visually, the lungs speak clearly. A shift from clear to purulent sputum often marks the turning point from irritation to infection. And moving into the Stand-Coast high-yield NCLEX Pearl, always document the color, amount, and consistency of sputum in all clients with respiratory infections. Report rust-colored sputum immediately, as it can signal pneumococcal pneumonia, or bloody sputum, which may indicate tuberculosis or malignancy. Encourage clients to maintain hydration of 2 to 3 liters per day to thin secretions, support airway clearance, and maximize the effect of guaifenesin. Remember, productive coughs should not be excessively suppressed with codeine unless necessary for rest. Overuse can trap mucus and worsen infection. Let us now move into an important respiratory pharmacology question that challenges your understanding of combination cough medications. A client with acute bronchitis has been prescribed a medication containing guaifenesin and codeine, commonly known as Robitussin AC. When the client curiously asks why this specific medication was chosen, the nurse must provide an accurate explanation regarding the role of codeine in this combination. The options are as follows. Option A relieves chest discomfort associated with coughing. Option B dilates the bronchi to improve airflow. Option C suppresses the cough reflex in the brainstem. And option D reduces inflammation of the airway mucosa. The correct answer is option C, suppresses the cough reflex in the brainstem. In this pharmacologic combination, each ingredient has a distinct role. Guaifenesin is an expectorant that helps loosen and thin mucus, promoting productive coughing and easier expulsion of secretions. Codeine, however, functions very differently. It acts on the central nervous system as a potent antitussive. Specifically, it binds to opioid receptors in the medulla oblongata, the area of the brain responsible for regulating the cough reflex. This action reduces the sensitivity of the cough center, thereby decreasing both the frequency and intensity of dry, non-productive coughs. This suppression allows the inflamed airways to rest and the client to sleep more comfortably, preventing exhaustion from continuous coughing. However, nurses must remember that codeine should only be used when a cough is non-productive and irritating, not when mucus needs to be cleared. Suppressing a productive cough can trap secretions, increase airway obstruction, and raise the risk of secondary infection. Because codeine is an opioid derivative, it can also cause sedation, constipation, and respiratory depression, especially in older adults or those with chronic respiratory diseases such as chronic obstructive pulmonary disease or sleep apnea. Therefore, nurses should always assess respiratory rate and level of consciousness before administration, encourage adequate hydration to thin mucus, and caution the client to avoid alcohol or operating vehicles after taking the medication. Now, let us briefly examine why the other options are incorrect. Option A, which states that it relieves chest discomfort, is partially true only in an indirect sense. Codeine may reduce cough-induced soreness, but its main function is not pain relief at the doses found in cough syrups. Option B, dilates the bronchi, is incorrect because bronchodilation is achieved through beta-2 agonists such as albuterol, not opioids. Option D, reduces inflammation, is also incorrect, since anti-inflammatory effects are produced by corticosteroids or non-steroidal anti-inflammatory drugs, not codeine. Transitioning now to the Stand-Coast clinical insight, we can say, cough suppression is therapeutic only when silence helps healing, never when the lungs are still trying to speak. The wise nurse knows when to quiet the reflex and when to let the body clear itself. Moving further to the Stand-Coast high-yield NCLEX Pearl, always assess whether a cough is productive or non-productive before giving any cough suppressant. Use guaifenesin-codeine combinations only for dry, irritating coughs, monitor for respiratory depression, and encourage hydration and humidification to support mucus clearance. Let us now move forward to a pharmacology-based question that focuses on the safe administration and client teaching of an opioid antitussive. A client diagnosed with acute bronchitis has been prescribed a cough syrup containing codeine. During discharge teaching, the nurse must ensure the client fully understands how to take this medication safely. The question asks, which nursing instruction is most appropriate to include regarding the safe use of this medication? The options are as follows. Option A, do not take the medication more frequently than prescribed. Option B, avoid taking the medication before going to sleep. Option C, increase fluid intake throughout the day. And option D, warm the cough syrup to improve its taste. The correct answer is option A, do not take the medication more frequently than prescribed. This question evaluates safe medication administration, pharmacologic principles, and patient education related to opioid antitussives, such as codeine. Codeine acts directly on the medullary cough center in the brainstem, suppressing the cough reflex and providing relief from persistent, non-productive coughs. However, because it is an opioid, it carries a significant risk of respiratory depression, sedation, constipation, and drug dependence when misused or overdosed. The most crucial nursing responsibility is to emphasize strict adherence to prescribed dosage and timing. Taking extra doses can lead to life-threatening central nervous system depression characterized by drowsiness, bradypnea, pinpoint pupils, and even coma. Therefore, teaching the client to follow the prescribed schedule precisely and to avoid any self-adjustment in dosing is vital for safety. Option A is correct because instructing the client not to take the medication more frequently than prescribed prevents opioid toxicity and misuse. Codeine's cumulative sedative and respiratory depressant effects can be dangerous, so nurses must reinforce dose discipline, explain early signs of overdose, and advise avoiding alcohol or other sedatives. Option B is incorrect because bedtime administration is actually recommended for clients with dry, irritating coughs, as it reduces nocturnal coughing and promotes restful sleep. Option C is also incorrect, since encouraging fluid intake applies to expectorants like guaifenesin, not to opioid antitussives like codeine. Extra fluids do not enhance codeine's action and may disturb sleep through frequent urination. Lastly, option D is incorrect because warming cough syrup can change its stability and may irritate the mucosa. Slightly chilling the syrup may make it more palatable without affecting its efficacy. Now, before we wrap up, let us uncover the deeper learning point through the Stan Coast clinical insight. Every opioid antitussive is a double-edged sword. When used wisely, it soothes. When misused, it silences more than just a cough. And finally, let us highlight the most exam-relevant takeaways in the Stan Coast High-Yield NCLEX Pearl. Codeine suppresses the medullary cough center and should be prescribed only for dry, non-productive coughs. Always assess respiratory rate, level of consciousness, and bowel pattern before each dose. Educate clients to avoid alcohol, sedatives, and driving until they understand how the medication affects them. Reinforce adherence to prescribed dosage and frequency to prevent respiratory depression and opioid dependence. Moving on to another essential question that focuses on safe medication administration. A nurse is preparing to administer a liquid cough syrup along with several other prescribed oral tablets to a client who has a persistent dry cough and throat irritation. The question asks, which nursing action demonstrates safe and evidence-based medication administration in this situation? Here are the options to consider. Option A, administer the cough syrup first, then the tablets. Option B, wait 15 minutes after giving the cough syrup before giving the tablets. Option C, give the cough syrup between administering the tablets. And option D, administer the tablets first, then the cough syrup. The correct answer is option D, administer the tablets first, then the cough syrup. This approach is supported by pharmacologic rationale and clinical best practice when both solid and liquid oral medications are prescribed. The rule of thumb is to give solid forms like tablets or capsules first, followed by viscous or demulcent syrups. Cough syrups often contain soothing agents such as glycerin or honey-based components designed to coat the throat, providing relief from irritation. Administering the syrup last ensures that its therapeutic layer remains in prolonged contact with the pharyngeal mucosa, maximizing its effectiveness and comfort for the client. If the nurse were to give the syrup first, the subsequent tablets and sips of water needed to swallow them would wash away that protective coating, significantly reducing its benefit. Similarly, waiting 15 minutes before or after syrup administration adds unnecessary delay and confusion to the medication routine without any clinical advantage. Giving the syrup between tablets is also inappropriate because it interferes with swallowing and can hinder proper absorption. Therefore, administering all tablets first followed by the cough syrup last not only ensures optimal drug absorption, but also allows the syrup to perform its intended function of soothing the throat. The nurse should also remember to advise the client not to drink water immediately after taking the syrup, as doing so dilutes its coating effect and diminishes its local action. Now, let us briefly discuss why the other options are not appropriate. Option A, giving the cough syrup first, is incorrect because the subsequent swallowing of tablets and water will wash away its soothing layer, defeating the medication's local purpose. Option B, waiting 15 minutes after the syrup, is also incorrect, because it disrupts workflow and provides no added therapeutic value. Option C, giving the syrup between tablets, is equally unsuitable as it can interfere with swallowing rhythm and may affect drug absorption or comfort. Transitioning now to NCLEX clinical insight. Order in medication. Administration is not arbitrary, it is strategic. Giving demulcent syrups last preserves their coating effect, ensuring comfort where it matters most, the irritated mucosa. And before we wrap up this concept, here comes your quick exam-focused takeaway. NCLEX high yield. NCLEX Pearl. Always administer solid oral medications first, followed by liquid preparations like syrups. Avoid rinsing or drinking water immediately after a medicated syrup to maintain its local therapeutic effect. Educate clients that these syrups are designed to soothe throat tissues and should not be followed by fluids unless specifically instructed. Remember, safe medication sequencing not only ensures systemic absorption, but also promotes local comfort and patient satisfaction. Let us move forward with another important question focusing on safe medication measurement and client education, particularly relevant in home settings where clients may lack proper tools for precise dosing. A nurse is teaching a client how to self-administer a prescribed liquid cough syrup with a dosage of 5 milliliters per dose. Which household measurement should the nurse instruct the client to use to ensure accurate administration? Here are the options to consider. Option A, 1 ounce. Option B, 1 tablespoon. Option C, 1 teaspoon. And option D, 1 capful. The correct answer is option C, 1 teaspoon. The reason behind this lies in understanding the equivalency between metric and household units. 5 milliliters is approximately equal to 1 teaspoon, and teaching this conversion is crucial in preventing dosing errors, particularly in clients administering medications at home. Medication measurement errors are one of the most preventable causes of accidental overdose, especially among children and the elderly. Nurses must ensure that clients not only understand the correct measurement, but also demonstrate it accurately before discharge. When analyzing the other options, 1 ounce equals approximately 30 milliliters, which would result in giving 6 times the prescribed dose, a serious error that could cause toxicity or respiratory depression if the cough syrup contains sedatives or opioids. Similarly, 1 tablespoon equals 15 milliliters, still 3 times higher than the intended dose, and can easily lead to overmedication. Meanwhile, using a capful is unsafe because bottle caps vary in size and are not standardized. Drinking directly from the cap also poses a contamination risk, especially when medications are shared within households. In practice, nurses should encourage clients to use a calibrated medication spoon, oral syringe, or dosing cup for liquid medications rather than household utensils. Additionally, instructing the client to measure the liquid at eye level helps ensure accuracy. Hands-on demonstration and client return demonstration, teach-back method, are essential to verify understanding and prevent errors after discharge. Transitioning to the next key insight. Here is your NCLEX clinical pearl. Before a client leaves the hospital or clinic, always confirm that they can physically demonstrate how to measure their liquid medication. This practical step transforms theoretical teaching into real-world safety and protects clients from accidental overdose caused by simple household miscalculations. Now, moving to your NCLEX high-yield NCLEX Pearl. Remember these crucial conversions. 5 milliliters equals 1 teaspoon, 15 milliliters equals 1 tablespoon, and 30 milliliters equals 1 ounce. Always teach patients to rely on calibrated measuring devices instead of kitchen spoons. Promote clear labeling and safe storage of liquid medications, and most importantly, use the teach-back method to ensure comprehension before the patient leaves care. Let us now move ahead to explore another vital NCLEX-style question that emphasizes the importance of understanding respiratory therapies in acute conditions. A client diagnosed with acute bronchitis receives a prescription for aerosol therapy as part of the treatment plan. The nurse reinforces teaching about this therapy, which statement by the client indicates an accurate understanding of the purpose of aerosol therapy. The available options are as follows. Option A, aerosol therapy relieves tissue irritation. Option B, this therapy kills infectious organisms. Option C, aerosolization dries respiratory passages. And option D, aerosol therapy helps to slow breathing. The correct answer is option A. Aerosol therapy relieves tissue irritation. Aerosol therapy plays a significant role in the supportive care of clients with respiratory tract inflammation, such as bronchitis, asthma, or chronic obstructive pulmonary disease. This therapy delivers fine, warm, and moist droplets directly to the mucosal surfaces of the respiratory tract. These tiny particles soothe the irritated airways, reduce inflammation, and help liquefy thick secretions that often obstruct airflow. As the mucus becomes thinner, it is easier for the client to expectorate, promoting better airway clearance and enhancing overall ventilation. In acute bronchitis, where inflammation and excessive mucus production commonly cause discomfort and a persistent cough, the primary aim of aerosol therapy is to restore moisture and comfort to the airways, not to treat infection directly. Let us analyze each option carefully for a deeper understanding. Option A, aerosol therapy relieves tissue irritation, is absolutely correct because the humidified mist helps reduce dryness, calm inflamed tissues, and support natural mucociliary clearance. Option B, this therapy kills infectious organisms, is incorrect since aerosol therapy itself does not possess antimicrobial properties. Bacterial infections are treated with antibiotics, not by humidification therapy. Option C, aerosolization dries respiratory passages, is the opposite of the truth. Aerosol therapy actually moistens the respiratory mucosa, and drying the airways would worsen irritation and coughing. Finally, option D, aerosol therapy helps to slow breathing, is also inaccurate because the therapy's purpose is not to alter respiratory rate, but to improve breathing comfort by reducing airway obstruction. Before we conclude, here comes an essential Stancoast clinical insight. When the airways are inflamed, they crave moisture. A simple mist can do what pills cannot: soothe, loosen, and restore the natural rhythm of breathing. Now let us highlight the Stancoast High-Yield NCLEX Pearl. Always teach clients that aerosol therapy serves a supportive function rather than a curative one. It improves comfort, enhances mucus clearance, and complements medication efficacy. Reinforce the importance of maintaining adequate hydration, practicing deep breathing and coughing exercises, and adhering to prescribed therapy to prevent mucus plugging and optimize respiratory recovery. Let me share something before we jump in.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us dive into this next advanced level NCLEX-style question that sharpens both your dosage calculation and clinical reasoning skills. A nurse is preparing to administer penicillin G potassium to an adult client diagnosed with streptococcal pneumonia. The prescription reads, penicillin G potassium 300,000 units intramuscularly every 6 hours. The vial label indicates each vial contains 1 million units of penicillin G potassium. Reconstitute with 9.6 milliliters of sterile water for injection to yield a final concentration of 100,000 units per milliliter. Now, the question is, how many milliliters of the reconstituted solution should the nurse draw up for 1 intramuscular dose, recording the answer to 1 decimal place? The correct answer is 3 milliliters. Let us now move through the rationale carefully. To begin, identify the essential details. The ordered or desired dose is 300,000 units, and the available concentration on hand is 100,000 units per milliliter. Applying the standard dosage formula, we have volume to administer equals desired dose divided by dose on hand per milliliter, which is 300,000 divided by 100,000, equaling 3 milliliters. In clinical terms, this means the nurse should withdraw 3 milliliters of the reconstituted penicillin G solution for administration. Because 3 milliliters is near the maximum volume that should be given at a single intramuscular site, the nurse may consider splitting the dose between 2 injection sites. Especially in frail or underweight patients, to reduce pain and ensure optimal absorption. Now let us interpret this pharmacologically. Penicillin G belongs to the beta-lactam antibiotic class and works by inhibiting bacterial cell wall synthesis, leading to cell lysis in susceptible organisms. It is used for streptococcal, pneumococcal, meningococcal, and certain syphilitic infections. Prior to administration, the nurse must confirm the correct salt form, whether potassium, procaine, or benzathine, assess for allergies, and keep epinephrine 1 mg per milliliter intramuscular readily available in case of anaphylaxis. Using the Z-track technique helps prevent irritation and leakage into subcutaneous tissue. Injection sites should be rotated, and the nurse must observe for local redness, pain, or induration after administration. In addition, storage and stability are critical. Reconstituted penicillin solutions should typically be used within the manufacturer's recommended timeframe, commonly less than 7 days if refrigerated to ensure potency. Finally, documentation should include the dose given, time, site, and any adverse reactions. Therapeutic effectiveness can be evaluated through decreased fever, improved breath sounds, and normalization of the white blood cell count. Transitioning to deeper clinical reasoning. Here is your Stand-Coast clinical insight. Every milliliter of penicillin carries both healing power and hypersensitivity risk. Precision in calculation protects efficacy, while vigilance in observation safeguards life. And moving to the Stand-Coast high-yield NCLEX Pearl, always calculate medication volumes using dimensional analysis or the standard formula before preparing the dose. Verify the route and maximum safe volume. Since more than 3 milliliters in a single intramuscular site increases pain and reduces absorption. Observe every client for at least 15 to 30 minutes, post-injection for any allergic reactions such as rash, difficulty breathing, or low blood pressure. Finally, remember that penicillin is measured in units, not milligrams, a common NCLEX trap that tests attention to detail and safe practice. Let us now explore another clinically rich NCLEX-style scenario that challenges both your critical thinking and diagnostic reasoning. A 56-year-old adult is admitted to the medical unit with a diagnosis of pneumonia. During assessment, the nurse observes shaking chills, a productive cough with rust-colored sputum, pleuritic chest pain, and a temperature of 104.2 degrees Fahrenheit, which equals 40.1 degrees Celsius. A chest X-ray confirms lobar consolidation, and sputum samples are collected for culture and sensitivity. To determine whether the pneumonia is bacterial or viral in origin, the nurse asks about the onset and progression of symptoms. The question is, which client statement best supports a bacterial rather than viral cause? Here are the options. Option A, it started with mild fatigue and sore throat about a week ago and slowly got worse. Option B, I suddenly began shivering and coughing up thick sputum just last night. Option C, it has been nearly 2 weeks since I developed nasal congestion and now I feel short of breath. Option D, I have had an on and off dry cough and low-grade fever for the past 10 days. The correct answer is option B, I suddenly began shivering and coughing up thick sputum just last night. Moving into the detailed rationale, bacterial pneumonia, most commonly caused by Streptococcus pneumonia, presents with a sudden and dramatic onset. Clients often develop shaking chills, a high fever exceeding 103 degrees Fahrenheit, pleuritic chest pain, and a productive cough with purulent or rust-colored sputum. This acute presentation reflects the rapid multiplication of bacteria within the alveoli, which triggers an intense inflammatory response and causes alveolar exudate formation. The infection typically results in consolidation of one or more lobes, a finding clearly visible on chest X-ray. The incubation period is generally brief, often only several hours to a couple of days. Therefore, a client describing an abrupt onset of chills and productive cough, as in option B, fits perfectly with a bacterial etiology. In contrast, viral pneumonia, often caused by influenza virus, respiratory syncytial virus, or adenovirus, has a slow and insidious onset. Clients usually experience upper respiratory symptoms first, such as nasal congestion, sore throat, and mild cough, that gradually worsen over several days. Fever tends to be lower, sputum is usually scant and non-purulent, and imaging shows diffuse interstitial infiltrates rather than lobar consolidation. Recognizing this distinction is essential because it guides the nurse in supporting early antibiotic administration for bacterial pneumonia and avoiding unnecessary antibiotic use for viral causes. Now, let us evaluate each option carefully. Option A is incorrect because its gradual onset with fatigue and sore throat over several days reflects viral pneumonia. Option B is correct, as its sudden presentation with chills, high fever, and productive cough indicates bacterial infection. Option C is incorrect, as 2 weeks of upper respiratory symptoms progressing to cough aligns more with viral or atypical mycoplasma pneumonia. Option D is also incorrect, as a mild dry cough and low-grade fever lasting many days correspond to a viral pattern or walking pneumonia. Transition to Stancoast. Clinical insight: bacterial pneumonia strikes fast and hard. Its abrupt fever, chills, and rust-tinged sputum signal alveolar invasion. Recognizing the rapid onset is the nurse's first clue to a bacterial cause. Transition to Stancoast high yield. NCLEX. Pearl. Always assess onset, sputum character, and fever intensity when differentiating bacterial from viral pneumonia. Rapid onset with purulent sputum and high fever indicates bacterial infection, whereas gradual onset with dry cough and mild fever suggests viral etiology. Let us smoothly transition into another essential NCLEX-style scenario that tests both practical preparation and clinical accuracy. A nurse is preparing a client for a routine chest X-ray in the radiology department. The question asks, which nursing action is absolutely essential before the X-ray is taken? The options are as follows. Option A, ensure the client has remained nil per oral or nothing by mouth for at least 6 hours before the procedure. Option B, remove all metallic objects, including necklaces, piercings, or clothing with metal fasteners. Option C, instruct the client to swallow the contrast dye provided by the technician. Option D, administer an analgesic to minimize discomfort during the imaging process. The correct answer is Option B, remove all metallic objects, including necklaces, piercings, or clothing with metal fasteners. Now, let us move into the advanced rationale behind this answer. Before performing a chest X-ray, it is crucial for the nurse to ensure that the client has removed all metallic objects from the chest and neck area. Metallic materials such as necklaces, buttons, piercings, bras with underwires, and zippers can obstruct or distort the radiographic image because metals are radiopaque. This means they appear white on the X-ray and may be misinterpreted as pathological findings like lung nodules, calcifications, or other abnormalities. Removing these objects ensures a clear, accurate diagnostic image that reflects true anatomic structures rather than artifacts. Additionally, the nurse should explain the procedure clearly to reduce client anxiety, emphasizing that a chest X-ray is quick, painless, and non-invasive. No fasting or contrast dye is required for this test. Proper client preparation prevents diagnostic confusion, avoids repeat exposure to radiation, and ensures accurate medical interpretation. Let us now analyze each option in detail. Option A is incorrect because fasting or dietary restriction is not required before a plain chest X-ray. Such instructions apply to procedures involving the gastrointestinal tract or those requiring contrast materials. Since a chest X-ray examines air-filled lung structures, there is no need for the stomach to be empty. Option B is correct, as removing all metallic objects ensures that no artificial shadows interfere with the image. This simple yet vital step prevents misdiagnosis and maintains image clarity. Option C is incorrect, because contrast dye is not used in routine chest X-rays. It is reserved for specialized studies such as computed tomography scans or angiography. Asking the client to swallow contrast dye before a chest X-ray would be inappropriate and potentially risky. Option D is also incorrect since chest X-rays are completely painless and non-invasive, so there is no indication for analgesic use. Now transitioning to the Stancoast clinical insight. Every X-ray begins with clarity, both in the image and in the preparation. Removing metal is not just a technical step. It is a safeguard against diagnostic confusion that ensures accurate interpretation and avoids unnecessary repeat exposure. And finally, moving into the Stancoast high-yield NCLEX Pearl. Always verify that the client has removed all metallic items before any radiographic procedure. Remember that fasting is not required for plain radiographs, such as chest or limb X-rays, and no contrast dye or sedation is needed for a standard chest film. Always educate and reassure the client that the procedure is quick, painless, and entirely safe. Let us now move into another high-level NCLEX-style clinical situation that emphasizes practical nursing judgment in respiratory care. A client diagnosed with bacterial pneumonia is having difficulty expectorating thick respiratory secretions, and the nurse needs to collect a sputum specimen for culture and sensitivity testing. The question asks, which nursing intervention should be prioritized to facilitate sputum collection? Here are the available options. Option A, provide the client with a generous fluid intake. Option B, encourage the client to change positions regularly. Option C, ask the dietitian to provide a clear liquid diet. Option D, administer an antitussive before collecting the specimen. The correct answer is Option A, provide the client with a generous fluid intake. When a client with pneumonia struggles to expectorate thick sputum, the nurse's first and most effective action is to promote systemic hydration. Increasing fluid intake to approximately 2 to 3 liters per day, if not contraindicated, helps thin the mucus, reduces its viscosity, and facilitates easier expectoration. This also keeps the mucous membranes moist and supports the mucociliary escalator mechanism, which plays a vital role in clearing microorganisms and debris from the airways. Additionally, humidifying the inspired air or oxygen can further prevent drying of the respiratory mucosa and make coughing more productive. The most optimal time to collect a sputum sample is early in the morning before breakfast, as secretions tend to accumulate overnight, ensuring a more representative specimen for accurate culture and sensitivity testing. Looking at the other options, Option B, encouraging the client to change positions regularly, is beneficial for lung expansion and drainage of secretions, but does not directly liquefy or loosen thick mucus. It serves as a secondary measure rather than the primary one. Option C, asking the dietitian to provide a clear liquid diet, is inappropriate in this situation because dietary changes require a physician's order and do not directly aid sputum expectoration. Instead, the nurse should focus on adequate hydration through oral fluids within the client's prescribed diet. Option D, administering an antitussive before sputum collection, is contraindicated because cough suppression would prevent the client from expectorating mucus, making it impossible to obtain a sputum sample. In fact, if medication is needed, an expectorant such as guaifenesin would be more suitable to stimulate productive coughing rather than suppress it. Transitioning to the Stan Coast clinical insight, it is essential to remember that hydration is the unsung hero of respiratory care. Before antibiotics clear infection, water clears the airway. Ensuring adequate hydration not only facilitates specimen collection, but also speeds recovery by improving oxygenation and decreasing airway obstruction. Now moving toward the Stan Coast High-Yield NCLEX Pearl, always encourage clients with pneumonia to maintain fluid intake between 2 and 3 liters per day, use humidified oxygen if prescribed, and collect sputum specimens early in the morning before meals for the best accuracy. Avoid administering cough suppressants before sputum collection to prevent secretion retention and diagnostic errors. Hey friend, pause for just a sec.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now explore another essential nursing scenario that focuses on timing and clinical precision in specimen collection. A nurse is preparing to collect a sputum specimen for culture and sensitivity testing from a client diagnosed with bacterial pneumonia. The question asks, at which time of day should the nurse plan to obtain the sputum sample to ensure the most accurate and effective results? Here are the available options. Option A, before bedtime. Option B, after a meal. Option C, between meals. Option D, on awakening. The correct answer is Option D, on awakening. Collecting a sputum specimen immediately after the client awakens in the morning provides the most accurate and diagnostically valuable sample. During sleep, respiratory secretions naturally accumulate within the airways because ciliary activity slows, allowing mucus and pathogens to pool. When the client wakes up, these secretions are thicker, more concentrated, and easier to expectorate before hydration, food intake, or oral hygiene can alter their composition. Morning collection also reduces contamination from food debris and oral bacteria, ensuring the sample truly represents the lower respiratory tract. If sputum remains difficult to obtain, a nebulized saline treatment may be administered beforehand to loosen secretions and promote effective expectoration. Now, let us analyze each option one by one. Option A, before bedtime, is incorrect because secretions have typically been expelled throughout the day by normal coughing and movement, and fatigue during the evening can make effective coughing harder. Option B, after a meal, is also incorrect since collecting sputum after eating increases the risk of vomiting or aspiration and may contaminate the specimen with food particles, compromising diagnostic accuracy. Option C, between meals, though seemingly reasonable, is not ideal either. By midday, hydration and activity dilute the mucus, making it less concentrated and diagnostically less valuable. Finally, option D, on awakening, stands correct because overnight stasis allows microorganisms and mucus to accumulate, offering a sample rich in pathogens with minimal contamination. This timing also aligns with laboratory best practices for accurate culture and sensitivity testing. Here is a Stand-Coast clinical insight every nurse should remember. Morning sputum is nature's diagnostic gift. Collected before breakfast, it carries the highest bacterial load and the purest sample from the lower respiratory tract. Now moving toward the Stand-Coast high-yield NCLEX Pearl. Always collect sputum specimens early in the morning before meals or oral hygiene. Have the client rinse the mouth with water to reduce contamination, encourage deep coughing from the chest rather than simple throat clearing, and promptly label and transport the specimen to the laboratory within 30 minutes for the most accurate results. Let us now move into another high-priority nursing education question that highlights precision in infection control and specimen handling. A nurse is teaching a client how to collect a sputum specimen for culture and sensitivity testing. The question asks, which client statement indicates a correct understanding of how to handle the sputum specimen container? The options are as follows. Option A, I should put gloves on before opening the container. Option B, I should wipe the container with an alcohol swab before and after use. Option C, I should wait until the container is nearly full before closing it. Option D, I must not touch the inside of the container or its lid. The correct answer is option D, I must not touch the inside of the container or its lid. Maintaining sterility of the sputum specimen container is the most critical principle for ensuring accurate microbiological testing. The inside of the container and lid are sterile surfaces that must remain uncontaminated until sputum is deposited. If a client's hands, gloves, or any object touches the inside surface, extraneous microorganisms can be introduced, leading to false culture results or inappropriate antibiotic treatment. Therefore, the nurse should teach the client to open the lid carefully, avoid any contact with inner surfaces, and close the container immediately after the sample is collected. This simple but vital step protects the specimen from environmental contamination, ensuring that the laboratory culture truly reflects the microorganisms from the lower respiratory tract. Let us briefly explore why the other options are not correct. Option A, which suggests wearing gloves before opening the container, is a good infection control habit but does not specifically preserve the sterility of the container. Gloves protect the individual but cannot prevent contamination if the sterile inner surface is touched. Option B, recommending wiping the container with alcohol, is incorrect because alcohol can destroy the organisms meant to be cultured and offers no benefit to the sterile inner surface. Finally, option C, suggesting that the container should be filled before closing, is unsafe. Leaving the lid open allows environmental contamination and should always be avoided. The container must be sealed immediately after sputum is obtained. Transitioning into a deeper clinical perspective, we arrive at the Stand-Coast clinical insight. In sputum collection, the invisible line between accuracy and contamination is the rim of the container. One careless touch can turn diagnostic truth into laboratory noise. Handle it like a surgical instrument. Moving forward to an NCLEX-focused reminder, here comes the Stand-Coast high-yield NCLEX Pearl. Always instruct clients not to touch the inner surface of the container or its lid. Collect sputum, not saliva, preferably early in the morning before eating or performing oral care. Seal the lid immediately and label the specimen right at the bedside Finally, ensure that it reaches the laboratory within 30 minutes to preserve the microbial integrity and diagnostic accuracy of the sample. Let us now move to another question that focuses on post-procedural nursing care and comfort management. After collecting a sputum specimen from the client for culture and sensitivity testing, which nursing action should the nurse perform immediately following the procedure? The options are as follows. Option A, administer oxygen. Option B, provide mouth care. Option C, offer nourishment. And option D, encourage ambulation. The correct answer is option B, which is to provide mouth care. After a sputum collection, the nurse's immediate priority is to restore comfort and uphold infection control by offering thorough mouth care. During sputum expectoration, clients often experience residual mucus, a bitter taste, or an unpleasant odor in the mouth. Providing mouth care not only removes these secretions, but also refreshes the oral cavity, prevents bacterial growth, and promotes client dignity after the procedure. Additionally, this step minimizes contamination risks for future samples and ensures the client feels clean and comfortable before resuming other activities or meals. Administering oxygen, as stated in option A, is unnecessary unless the client shows clinical signs of hypoxia, which are not expected after sputum collection. Option C, offering nourishment, should be postponed until oral hygiene is completed to prevent ingestion of residual microbes that might lead to gastrointestinal irritation. Option D, encouraging ambulation, is unrelated to immediate post-specimen collection care and should be deferred until the client has fully rested and airway clearance is achieved. Therefore, providing mouth care demonstrates the nurse's competence in infection control, patient-centered care, and proper prioritization of comfort and safety after diagnostic procedures. Transitioning into clinical wisdom, here is the Stancoast clinical insight. Every diagnostic procedure must end with comfort care. After sputum collection, the nurse's simple act of mouth care restores dignity, promotes cleanliness, and prevents cross-contamination, turning a technical task into compassionate nursing. And now, the Stancoast High-Yield NCLEX Pearl. Always perform mouth care immediately after sputum collection to enhance comfort and hygiene. Document the color, consistency, amount, and odor of the sputum before discarding materials. Never allow the client to eat or drink before completing oral care, as this may introduce residual pathogens into the gastrointestinal tract. Finally, ensure that the specimen is sent to the laboratory within 30 minutes for the most accurate diagnostic results. Let us now transition into an advanced level NCLEX-style question that tests your understanding of respiratory complications. The nurse is assessing a client who was recently diagnosed with bacterial pneumonia. Which assessment finding most strongly suggests that the client has developed pleurisy as a secondary complication of the infection? The options are as follows. Option A, productive cough. Option B, pain when breathing. Option C, cyanotic nail beds. And option D, rapid heart rate. The correct answer is option B, which is pain when breathing. Pleurisy, also known as pleuritis, is an inflammation of the parietal and visceral pleura, the thin membranes surrounding the lungs and lining the chest cavity. When these pleural layers become inflamed, they lose their smooth, lubricated surface and begin to rub against each other with each breath. This friction causes sharp, stabbing pain that intensifies with deep inspiration, coughing, or sneezing. The pain is often localized to one side of the chest and may radiate to the shoulder or abdomen. Clients frequently describe the sensation as knife-like and may instinctively hold their breath or lie on the affected side to reduce the discomfort caused by pleural movement. In cases of bacterial pneumonia, pleurisy develops when the infection extends from the lung tissue to the pleural membranes. This inflammatory extension results in a pleural friction rub, which can be heard as a coarse, grating sound during auscultation. Detecting this early sign is critical because untreated pleurisy can progress to pleural effusion, in which fluid accumulates in the pleural space, or empyema, where pus collects and further impairs lung expansion. Early recognition and management of pleuritic pain can prevent these severe complications and promote better oxygenation and comfort. As for the other options, let us analyze why they are incorrect. Option A, productive cough, is a classic symptom of pneumonia itself, due to the accumulation of mucus and inflammatory exudate in the bronchioles and alveoli, but it does not indicate pleural involvement. Option C, cyanotic nail beds, reflect hypoxemia, low oxygen levels in the blood, caused by impaired gas exchange in the lungs, However, it is not specific to pleuritic inflammation. Option D, rapid heart rate or tachycardia, often occurs as a physiological response to infection, fever, or respiratory distress, but lacks diagnostic specificity for pleurisy. Therefore, among all the presented findings, pleuritic pain, sharp pain that worsens with breathing, is the most distinct and diagnostic feature of pleurisy secondary to pneumonia. Transitioning to clinical application, Stancoast. Clinical insight, pleuritic pain acts as the body's alarm bell for pleural inflammation. Each breath scrapes across an inflamed surface, transforming normal respiration into painful awareness. Recognizing this sharp, localized pain early allows the nurse to detect pleural involvement before more serious complications, such as pleural effusion or empyema, develop. And now for the Stancoast High-Yield NCLEX Pearl. Always assess for pleural friction, rub in clients with pneumonia who report chest pain during respiration. Encourage the client to splint the affected side while coughing to minimize pain and reduce pleural irritation. Monitor for shallow breathing or decreased expansion on the affected side, which may signal that pain is limiting ventilation. Administer prescribed analgesics promptly and position the client on the affected side to promote comfort and limit pleural movement. Let us smoothly move into our next advanced level NCLEX-style question, which focuses on evidence-based antibiotic therapy and rational drug selection. A client diagnosed with pneumococcal pneumonia is prescribed penicillin G-benzathine, also known as Bicillin, for intramuscular administration. The client asks the nurse, "Why did my physician choose this particular antibiotic for my infection?" Here are the available options for this question. Option A states, "The culture and sensitivity test confirmed that the causative organism is susceptible to penicillin." Option B says, "Most viral respiratory infections improve when treated with penicillin-based drugs." Option C explains, "Penicillin is one of the safest and most universally effective antibiotics for all infections." And option D suggests, "All antibiotics act in similar ways." So the choice of drug is not very important. The correct answer is option A, which states that the culture and sensitivity test confirmed that the causative organism is susceptible to penicillin. Pneumococcal pneumonia is a bacterial infection most commonly caused by Streptococcus pneumonia. The gold standard for antibiotic selection involves performing a culture and sensitivity test. This laboratory test identifies the specific microorganism and determines which antibiotic is most effective against it. During testing, bacterial colonies are exposed to antibiotic discs, and if a clear zone forms around a specific drug like penicillin, it signifies that the bacteria are sensitive to that medication. This method ensures targeted treatment and avoids unnecessary antibiotic exposure. Penicillin G-benzathine is a narrow-spectrum beta-lactam antibiotic that works by inhibiting bacterial cell wall synthesis. It binds to penicillin-binding proteins within the bacterial membrane, preventing the cross-linking of peptidoglycan chains. This process weakens the bacterial cell wall, leading to rupture and cell death. Because Streptococcus pneumonia remains highly susceptible to penicillin, Bacillin continues to be an effective first-line therapy for non-resistant infections. The intramuscular form provides a sustained release of the drug, maintaining therapeutic levels over time and reducing dosing frequency, which enhances client compliance. From a safety and nursing standpoint, before administering penicillin, the nurse must verify if the client has any known allergy to penicillin or beta-lactam antibiotics. Allergic reactions can range from mild rashes to severe anaphylaxis. Therefore, close observation for signs of hypersensitivity, such as hives, facial swelling, or difficulty breathing, is essential. If such reactions occur, administration must be stopped immediately, and emergency interventions including epinephrine should be initiated. Let us now summarize the pharmacologic rationale concisely. The mechanism of action involves inhibition of bacterial cell wall synthesis. Its antibacterial spectrum primarily covers gram-positive organisms, particularly S. pneumonia. The formulation advantage lies in its long-acting depot preparation suitable for intramuscular administration. The nursing focus should always include allergy assessment, monitoring for adverse effects, and client education on completing the entire course to prevent relapse or resistance. Now turning to the incorrect options, option B is inaccurate because antibiotics do not treat viral infections. Viruses lack a cell wall, the target site of penicillin's action. Using antibiotics unnecessarily for viral infections promotes microbial resistance and disrupts normal flora. Option C, while partially true in suggesting penicillin's safety, is incorrect because not all bacteria respond to it. Many gram-negative organisms produce beta-lactamase enzymes that destroy penicillin's effectiveness unless combined with a beta-lactamase inhibitor. Hence, antibiotic therapy should always be guided by laboratory results. Option D is entirely false since antibiotics vary widely in mechanism, coverage, and side effect profiles. Rational drug selection must be based on infection site, pathogen sensitivity, and patient-specific factors such as renal function and allergy history. Transitioning into our NCLEX clinical insight. Before jumping to any antibiotic choice, always remember that every culture plate tells a precise microbiologic story. Guessing the right drug without sensitivity data is equivalent to gambling with antibiotic resistance. Culture-guided therapy ensures precision and preserves antibiotic effectiveness. Moving into our NCLEX high-yield NCLEX Pearl. Always collect the culture and sensitivity specimen before starting antibiotic therapy. Verify any penicillin allergy before administration. Remember that penicillin G-benzathine should never be substituted with oral penicillin formulations. Observe the client for at least 30 minutes post-injection for allergic reactions. Lastly, educate every client to complete the full antibiotic course, even if symptoms subside early, as incomplete treatment may lead to relapse and resistance. Let us progress into our next advanced level NCLEX-style question that emphasizes the importance of medication safety and cross-sensitivity awareness. A nurse is reviewing the medication orders for a client with a documented allergy to penicillin. The critical question here is, which other class of antibiotics should the nurse anticipate a potential cross-hypersensitivity reaction with? Here are the available options for this clinical scenario. The first option suggests aminoglycosides such as kanamycin, Cantrex. The second option lists tetracyclines such as doxycycline, vibromycin. The third option mentions cephalosporins such as ceftriaxone, Rosifin. And finally, the fourth option includes fluoroquinolones such as ciprofloxacin, Cipro. The correct answer is option 3, cephalosporins such as ceftriaxone, Rosifin. Now let us explore the expanded advanced rationale in depth. A client with a true penicillin allergy is at increased risk for cross-reactivity to cephalosporins because both drug classes share a similar beta-lactam ring structure. This chemical ring is responsible for their antibacterial action by inhibiting bacterial cell wall synthesis. Unfortunately, this shared structure can confuse the immune system of a penicillin-allergic client, triggering a cross-hypersensitivity response. Such immune misrecognition can manifest as anything from mild urticaria and skin rashes to severe, life-threatening anaphylaxis. Evidence suggests that around 5 to 10% of clients allergic to penicillin may experience cross-sensitivity reactions with first-generation cephalosporins like cefazolin, while newer generations such as ceftriaxone tend to have a much lower risk. Before administering any cephalosporin, the nurse must carefully assess the allergy history, including the type and severity of the previous reaction to penicillin. If the provider decides that the cephalosporin is essential, the nurse should administer the medication cautiously while monitoring the client for early signs of hypersensitivity, including rash, itching, dyspnea, wheezing, or hypotension, especially during the first few minutes after injection. It is equally vital to document the type of allergic reaction, onset, and treatment provided, as this record guides all future antibiotic therapy decisions. On the other hand, aminoglycosides, tetracyclines, and fluoroquinolones are chemically distinct from penicillins and do not share the beta-lactam structure, making cross-reactivity extremely unlikely. While each class can still cause independent allergic reactions, these are not immunologically related to penicillin sensitivity. Transitioning into our NCLEX clinical insight, remember this key perspective. Cross-reactivity is a biochemical echo of the immune system's memory. When one antibiotic structure mirrors another's, a past allergy can reawaken. Always check, confirm, and clarify before you inject. Moving into our NCLEX high-yield NCLEX Pearl, keep these essential reminders in mind. Penicillin and cephalosporins share a beta-lactam ring, forming the molecular foundation of cross-allergy risk. Always clarify the nature of the allergic reaction. A mild rash may not absolutely contraindicate cephalosporin use, but a history of anaphylaxis does. Document all allergies in a highly visible manner, apply allergy alert bans, and always have epinephrine, oxygen, and emergency equipment readily available when giving the first cephalosporin dose to a penicillin-allergic client. Let us move forward into another essential NCLEX-style scenario that focuses on client safety during immunization campaigns. During a community-wide vaccination drive, a nurse is preparing to administer influenza vaccines to older adults. Before proceeding with the injection, the nurse must determine which question is most critical to ensure client safety and prevent adverse reactions. Here are the available options to consider carefully. The first option asks, have you had influenza in the last year? The second option inquires, did you receive the pneumonia vaccine last year? The third option asks, are you allergic to eggs or egg products? And the fourth option explores, do you have a history of respiratory disease? The correct answer is option 3. Are you allergic to eggs or egg products? Now, let us unfold the detailed advanced rationale behind this answer. Before administering the influenza vaccine, the nurse must always assess for a history of allergy to eggs or egg-derived substances. Most influenza vaccines are cultured in embryonated chicken eggs, leading to trace amounts of residual egg proteins such as ovalbumin in the final product. In clients who are allergic to eggs, even minimal exposure can provoke allergic reactions that range from mild urticaria or respiratory wheezing to severe, life-threatening anaphylaxis. Therefore, verifying egg allergy before immunization is a fundamental step to safeguard the client. In line with the latest guidelines from the Centers for Disease Control and Prevention and the Advisory Committee on Immunization Practices, individuals with mild egg allergies, such as localized hives, can safely receive inactivated influenza vaccines under close observation. However, clients who have experienced severe allergic reactions, such as respiratory distress, angioedema, or anaphylaxis, should be vaccinated only in medical settings equipped for emergency management, including immediate access to epinephrine and airway equipment. For clients with known severe egg allergies, recombinant or cell-based influenza vaccines, which are egg-free formulations, are considered the safest alternatives. It is also important to remember that older adults, particularly those above 65 years of age, are at heightened risk for influenza-related complications due to reduced immune responsiveness and chronic comorbidities such as diabetes, cardiovascular disease, and chronic respiratory illnesses. Thus, annual vaccination remains the cornerstone of preventive care, reducing the incidence of pneumonia, hospitalization, and influenza-related mortality in this vulnerable group. Moving on to the reasoning behind why the other options are incorrect. Option 1, have you had influenza in the last year, is incorrect because previous influenza infection does not confer long-term protection against evolving viral strains. Immunity from natural infection diminishes over time, and influenza viruses mutate frequently. Therefore, annual vaccination remains necessary. Option 2, did you receive the pneumonia vaccine last year, is also incorrect. While both pneumococcal and influenza vaccines are recommended for older adults, they target different pathogens. The pneumococcal vaccine protects against Streptococcus pneumoniae, a bacterium, while the influenza vaccine targets a virus. Receiving one does not affect the indication or timing of the other. Option 4, do you have a history of respiratory disease, is incorrect as well. In fact, individuals with chronic respiratory diseases such as asthma or chronic obstructive pulmonary disease are at increased risk for severe influenza complications and should definitely receive the vaccine rather than avoid it. Now transitioning into the Stan Coast clinical insight, every vaccine conversation begins with a safety screen. In older adults, a single missed question about egg allergy can turn prevention into an emergency. Always assess, anticipate, and act before the injection. Finally, let us conclude with the Stan Coast High-Yield NCLEX Pearl. Always verify and document allergy history, especially to eggs, latex, or previous vaccine doses, before giving any immunization. For clients with mild egg sensitivity, proceed under careful supervision, but for those with severe allergies, choose recombinant, egg-free formulations. Ensure vaccines are administered annually, ideally before the seasonal peak between October and March, to provide optimal immune protection. Before we begin, I want to share something that has already helped more than 100,000 nursing students achieve success.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us smoothly transition into another advanced level NCLEX-style scenario that focuses on community health education and preventive nursing. Imagine a nurse conducting a counseling session for older adults and individuals with chronic respiratory disorders, aiming to reduce influenza transmission during flu season. The nurse emphasizes preventive strategies beyond vaccination and asks which advice is most effective in reducing the risk of contracting influenza. Here are the options to consider. Option A suggests consuming adequate vitamin C daily. Option B advises avoiding crowded public places during flu season. Option C recommends dressing warmly during cold weather. Option D highlights reducing daily stress and anxiety. The correct answer is Option B, avoid crowded public places during flu season. Now, let us unfold the expanded advanced rationale behind this choice. Influenza is primarily spread through respiratory droplets produced when an infected individual coughs, sneezes, or even talks. These droplets can travel up to 6 feet and may be inhaled directly or transferred through contaminated surfaces. Crowded areas such as theaters, shopping centers, and public transport increase the likelihood of inhaling these infectious droplets, making avoidance of such places the most effective secondary preventive strategy after vaccination. Although maintaining a good intake of vitamin C, Option A, dressing warmly, Option C, and reducing stress, Option D, all support general wellness, none directly prevent influenza transmission. Vitamin C may slightly shorten the duration of symptoms, but does not stop viral infection. Dressing warmly only prevents hypothermia, not viral illness. Managing stress helps immune function, but cannot substitute for infection control measures. According to the Centers for Disease Control and Prevention, CDC, and the Advisory Committee on Immunization Practices, ACIP, high-risk populations, such as adults over 65 years, pregnant women, healthcare workers, and clients with chronic illnesses like asthma, diabetes, or cardiovascular disease, should receive annual vaccination and follow additional precautions. These include avoiding crowds, maintaining strict hand hygiene, wearing masks during outbreaks, and minimizing exposure to symptomatic individuals. In healthcare or long-term care settings, nurses also play a vital role by enforcing droplet precautions, isolating affected clients, and reinforcing respiratory etiquette like covering the mouth and nose during coughing or sneezing. Public health nurses must remind communities that influenza viruses mutate annually, and infection control behaviors complement but do not replace vaccination. Now, transitioning into the Stancoast clinical insight, before every influenza season, nurses become the frontline educators protecting communities. A single session teaching clients to avoid crowds can prevent severe illness and hospitalization. Remember, community prevention begins with nurse-led awareness. Finally, let us conclude with the Stancoast High-Yield NCLEX Pearl. Influenza spreads mainly through respiratory droplets and close contact, not through cold exposure. High-risk individuals include older adults, clients with chronic diseases, and those who are immunocompromised. Annual vaccination remains primary prevention. Avoiding crowded places serves as essential secondary prevention. Reinforce consistent hand hygiene, mask use, and avoidance of face touching to interrupt viral transmission. Let us now transition into our next advanced level NCLEX-style question that emphasizes clinical judgment and timely pharmacological intervention. A 45-year-old client presents to the outpatient clinic with fever, chills, myalgia, sore throat, and nasal congestion that began approximately 24 hours ago. The healthcare provider prescribes oseltamivir, also known as Tamiflu. When educating this client, which statement should the nurse stress as essential for ensuring maximum drug effectiveness? Here are the options to consider. Option A states, Tamiflu must be started within 12 to 24 hours after the first appearance of flu symptoms. Option B suggests, Tamiflu must be taken on an empty stomach for proper absorption. Option C advises, Tamiflu can affect liver function, so liver enzymes should be monitored before each dose. Option D asserts, Tamiflu works best when administered intranasally to target respiratory viruses directly. The correct answer is Option A, Tamiflu must be started within 12 to 24 hours after the first appearance of flu symptoms. Now, let us dive into the expanded advanced rationale behind this answer. Oseltamivir, Tamiflu, belongs to the neuraminidase inhibitor class of antiviral drugs. It blocks the neuraminidase enzyme, which is essential for the release of newly formed influenza viruses from infected host cells. By doing so, it halts viral replication and helps contain the spread of infection within the respiratory tract. However, this mechanism is only effective during the early phase of infection. That is, while the virus is actively replicating. For best results, therapy must begin as early as possible, ideally within 12 to 24 hours of symptom onset, and no later than 48 hours. Delayed initiation reduces its ability to limit viral replication, although it may still shorten illness duration by 1 to 2 days if started slightly late. Tamiflu is typically prescribed as 75 milligrams twice daily for 5 days and can be taken with or without food. Although food is not required for absorption, taking it with meals can reduce gastrointestinal discomfort, such as nausea or vomiting. Routine liver enzyme monitoring is unnecessary since oseltamivir is excreted mainly through the kidneys rather than metabolized by the liver. It is also important to note that oseltamivir is administered orally, not intranasally. Intranasal antivirals such as zanamivir, Relenza, are different drugs and may be contraindicated in clients with asthma or chronic obstructive pulmonary disease. Early initiation of oseltamivir is especially vital in high-risk groups, including older adults, immunocompromised clients, pregnant women, and those with chronic cardiac or pulmonary conditions, as it can significantly reduce complications like viral pneumonia or secondary bacterial infections. The nurse's role is to emphasize the importance of early initiation, adherence to the complete 5-day regimen, and recognition of possible side effects such as nausea, vomiting, or, rarely, neuropsychiatric effects in pediatric populations. Let us now review why the other options are incorrect. Option B is incorrect because oseltamivir absorption is not affected by food. It can be taken with or without meals, and food may actually minimize nausea. Option C is incorrect since oseltamivir is primarily eliminated renally, and routine liver enzyme tests are not necessary unless the client has known hepatic impairment. Option D is also incorrect because oseltamivir is not administered intranasally. Administering it through that route would render it ineffective and potentially unsafe, as the nasal antiviral zanamivir is a different formulation altogether. Now transitioning into the Stan Coast clinical insight. In influenza management, timing is the treatment. Every hour after symptom onset shifts the balance between viral containment and viral conquest. Start early, act fast, and stop the virus before it multiplies. Finally, let us conclude with the Stan Coast high-yield NCLEX Pearl. Begin oseltamivir therapy within 12 to 48 hours of symptom onset for best efficacy. Educate clients that Tamiflu does not cure influenza, but reduces symptom severity and duration. Reinforce completing the entire 5-day regimen, even if symptoms improve early. Encourage clients, especially high-risk individuals, to seek medical attention promptly for flu-like symptoms. Remind clients that annual influenza vaccination remains the most effective preventive strategy, while antivirals serve as a supportive, secondary measure. Let us now smoothly transition into our next advanced level NCLEX-style question that focuses on respiratory assessment and critical thinking in nursing care. Imagine a nurse caring for a hospitalized client diagnosed with influenza who suddenly begins to show subtle signs of respiratory compromise. The nurse suspects the development of hypoxia and must determine which assessment findings best support this suspicion. To explore this further, here are the options we need to consider. Option A mentions a cough, which is often associated with respiratory irritation. Option B highlights restlessness, a change that could signal early oxygen deprivation. Option C presents fever, a common symptom of infection. Option D introduces tachypnea, which refers to an increased respiratory rate. Option E identifies the use of accessory muscles to breathe, suggesting respiratory distress. Finally, option F lists cyanosis, a physical manifestation of inadequate oxygenation. After evaluating all the clues, the correct answers are option B, restlessness, option D, tachypnea, option E, use of accessory muscles to breathe, and option F, cyanosis. Now let us transition into the expanded rationale to understand why these options are correct. Recognizing both early and late indicators of hypoxia is crucial because timely intervention can prevent respiratory failure. Hypoxia, by definition, occurs when there is insufficient oxygen reaching the tissues despite adequate blood flow. The earliest and most sensitive indicator of hypoxia is restlessness. This occurs because the brain, being extremely sensitive to oxygen deprivation, reacts quickly by triggering symptoms such as agitation, anxiety, and confusion. These are the first warning signs before any noticeable physical respiratory distress becomes evident. Furthermore, tachypnea, or rapid breathing, develops as the body's compensatory response to low oxygen levels. This happens because chemoreceptors in the brainstem detect increased carbon dioxide and decreased oxygen levels, prompting an increase in the respiratory rate to enhance oxygen diffusion. This is the body's immediate attempt to maintain adequate oxygen supply to vital organs. As the situation progresses and the increased respiratory rate is no longer sufficient, the body begins to recruit accessory muscles, such as the sternocleidomastoid, scalene, and intercostal muscles, to assist with breathing. This visible effort indicates escalating respiratory distress and signals that gas exchange is becoming severely impaired. Eventually, if the condition continues to worsen, cyanosis appears as a late and ominous sign. The bluish discoloration of the lips, nail beds, and mucous membranes occurs when oxygen saturation drops below 85%. By the time cyanosis is visible, tissue hypoxia is already severe and requires immediate oxygen therapy or even advanced airway management to restore adequate oxygen levels. On the other hand, let us not forget why the remaining options are incorrect. Cough and fever are classic signs of infection and inflammation, commonly seen in influenza, but they do not directly indicate tissue hypoxia. While these findings may accompany the illness, they are not specific markers of oxygen deprivation. Clinically speaking, in clients with influenza or pneumonia, hypoxia develops due to alveolar inflammation, mucosal edema, and impaired gas exchange. Therefore, a vigilant nurse must always differentiate infection-related symptoms such as cough and fever from early hypoxic signs like restlessness and tachypnea. By recognizing these early indicators and initiating prompt oxygen therapy, the nurse can prevent progression to life-threatening respiratory failure or cardiac arrest. Now transitioning into the Stand-Coast clinical insight. When oxygen drops, the brain panics first, the lungs fight next, and the skin surrenders last. Recognizing restlessness before cyanosis is the hallmark of a vigilant nurse. Finally, let us conclude with the Stand-Coast high-yield NCLEX Pearl. Early signs of hypoxia include restlessness, anxiety, and tachypnea. Late signs of hypoxia include cyanosis, confusion, and bradycardia. Always assess airway, breathing, and circulation before interpreting infection-related symptoms. Continuous pulse oximetry and timely oxygen therapy remain the nurse's strongest tools to prevent hypoxic injury. To smoothly transition into our next high-level NCLEX-style question, picture this scenario that truly tests your understanding of fluid balance and geriatric care. An elderly client living in an assisted living facility has been diagnosed with influenza. The nurse observes that the client's temperature is 104.6 degrees Fahrenheit, accompanied by a dry cough, muscle aches, and a headache. The nurse instructs the nursing assistant to encourage oral fluid intake throughout the day. The question now becomes, if the client's cardiovascular and renal functions are normal, what should be the appropriate 24-hour oral fluid intake goal for this client? Here are the options to consider. Option A suggests 500 milliliters. Option B indicates 1,000 milliliters. Option C recommends 1,500 milliliters. And option D proposes 3,000 milliliters. The correct answer is option D, 3,000 milliliters. Moving forward into the detailed rationale, let us break this down physiologically. A fever of 104.6 degrees Fahrenheit reflects a hypermetabolic and catabolic state, where the body rapidly loses fluids through sweating, increased respiratory effort, and insensible losses from the lungs. In influenza, the immune system's heightened response increases the body's metabolic activity, which subsequently raises both hydration and thermoregulation needs. Encouraging a fluid intake of about 3,000 milliliters in 24 hours, approximately 3 liters, helps prevent dehydration, promotes effective mucociliary clearance, and maintains renal perfusion for the elimination of metabolic waste products. Adequate hydration also keeps mucus thin, preventing airway obstruction and reducing the risk of secondary bacterial pneumonia, a serious complication among elderly influenza patients. However, this recommendation applies only when cardiac and renal function are within normal limits. In clients with heart failure, chronic kidney disease, or pulmonary edema, excessive fluid intake could result in fluid overload, dyspnea, or edema. Thus, fluid intake must always be individualized under the healthcare provider's supervision. Dividing fluids throughout the day using water, clear soups, broths, electrolyte drinks, and fruit juices ensures comfort and compliance. Additionally, elderly individuals often have reduced thirst sensation, so encouraging frequent small sips is essential to meet hydration goals safely. Now, let us consider why the remaining options are incorrect. Option A, 500 milliliters, is drastically insufficient and would worsen dehydration. Option B, 1,000 milliliters, does not adequately replace insensible losses during fever. Option C, 1,500 milliliters, is an improvement but still fails to sustain mucosal hydration and renal perfusion required for optimal recovery. Transitioning now to the Stand-Coast clinical insight. Every degree above normal body temperature increases metabolic demand by nearly 10%. In febrile elderly clients, water acts as natural therapy. Each sip enhances circulation, flushes toxins, and helps the body cool down effectively. And here comes the Stand-Coast high-yield NCLEX Pearl. Adults with fever and normal cardiac or renal function should aim for 3 liters of fluids per day. Encourage consistent water and clear fluid intake, monitor intake and output, and check for dehydration indicators, such as dry mucous membranes, dark urine, or reduced skin turgor. Always individualize hydration plans based on comorbid conditions, medication regimens, and provider recommendations.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.